and for people on your teams that you want to share the information with in the future. So thank you for your understanding. Keisha, are you ready to get started? I'm happy to welcome everyone and then
Can you
kick it
repeat
over
what
to
you said when I was logging on? I didn't quite hear. You said something about
you.
other people.
I said that we are recording today's session just so that both those organizations that couldn't make it today, as well as others on your team that you want to share it with, we usually share the link out afterwards. Also, if you just want to review some detail you may have missed in the future. So appreciate your understanding.
Thank you.
So thanks everyone for being here this morning. There's a lot to cover. We have a lot of updates and information. We're so excited that the state policy is moving forward and allowing us to be able to share more and more with you all about this exciting initiative. So I will turn it over to Keisha Barr. And just so you understand a little bit about our growing and expanding team structure, Keisha has been promoted to the managing director for the whole UNYC network. So she is your go-to for everything related to community-based organization participation. And we also have Natalie Tobier, Managing Director of Healthcare Community Partnerships Capacity Building. And she is your go-to for everything related to healthcare. If you're a community health center or a health system, and you're trying to think through, how to collaborate with the social care network, Natalie is your go-to. And of course, I'm always still available to you anytime. You can always email me, call me. I make myself very accessible. So please, no question is too small. So we want we want everybody to know that we are here for you. You don't need a formal invitation or a formal meeting to work with us. You are all our partners on this journey together. So please do communicate with us. Keisha?
Thanks, Zach. Welcome everyone. I think this is the second convening of our social care network CBO work group. As mentioned during last month's meeting, we established this work group to ensure a forum to provide you, our community-based partners, with updates on SCN implementation planning activities, to allow you the opportunity to inform decisions about the SCN and, to the best of our ability, answer your questions around, what does this mean for your organizations? How will we work together, etc. A quick rundown of the agenda. As Zach mentioned, we want to ensure that we spend some time at the top of the call providing you with a brief update on where we are in the timeline of SCN activities to date, and then also spend some time aligning some of our recent accomplishments and efforts that are currently underway to the expectations and milestones that the state has of us in ensuring readiness for a January 1 service delivery go live. And then as Zach mentioned, we will pivot to spend the latter half of the call reviewing our region's fee schedule. As Zach mentioned earlier in the week, the state shared our final fee schedule, and Zach will lead us through a walkthrough of the fee schedule and highlight, potential areas of concerns about rates that have been approved by the state and potential implications for organizations that might be providing these services on the behalf of the network. So in the interest of time, and because I know the fee schedule discussion will likely elicit lots of questions, let's get started. So on this slide, it just shows a high-level summary of where we started and where we are to date. Since the awards were announced privately in July and publicly in August, there's been a flurry of activity both at the SCNs and the state level in support of implementation planning. As you are aware, because you are on this call, which is actually an output of this activity, back in early August, we released a solicitation for those organizations who were interested in participating in the SCN as a CBO and or on the SCN's governing body. Every organization that is represented on today's call apply to participate in our region's SCN as a CBO. Many of you, which I'll highlight a little later in the call, have already formalized that relationship through the execution of a participant agreement. Others are likely still in the contract execution process and probably still reviewing the agreement within your respective organizations. The day after we released our call for application or request for application, the state published the SCN operations manual. Because the manual is still considered a draft, while we can and have been sharing requirements as documented in the manual, unfortunately, we are not yet in a position where we are allowed to share it in its entirety with our network partners. We are eagerly anticipating the state to share the final manual any day now. And once it is made available and we are giving the green light to share it with our network partners, we will do so. A few additional milestones that have since been accomplished. We submitted our final budgets to the state back in August and finalized our work plans, which include several milestones that we as social care networks will be required to meet and report on as a part of our quarterly reporting back to the state. Many of these milestones we are already reporting progress against informally during our standing and ad hoc checkpoints with DOH. Back in late August, the state released us a preliminary fee schedule, as you are aware, and allowed the SCNs the opportunity to provide input into the schedule. Many of you on this call were engaged during the process to provide your subject matter expertise that informed our proposed revisions to the fee schedule, as well as the final fee schedule that was produced earlier in the week, which, as I mentioned earlier, Zach will review during the second half of the call. Fast forward to September, we finalized our contract as SCN lead entity with DOH. Soon thereafter, the state shared the model contract that the SCNs and managed care organizations must execute. There were a couple iterations of that contract that were released, and I'll talk a little bit more about where we stand with MCO contracting later in the presentation, but I can say that efforts are still underway to execute our contracts with regional MCOs, and we are anticipating there to be 14 or 15. I believe one of the organizations no longer has an active MLTC plan, but we are anticipating there to be 14 regional MCOs that we as a network will be required to execute contracts with. Some of our more recent October related accomplishments. Last week, we released the call for application for those providers, healthcare and behavioral health organizations who are interested in contracting with the SCN, another item which will be covered in a bit more detailed later. Perhaps one of our more notable recent accomplishments is that last Friday, we officially kicked off our SCN's governance committee. Several of you on the call were selected to sit on the committee and participated in the kickoff, and myself, and I'll probably punt it over to Zach as well. We'll talk a little bit more about some of the key observations and learnings from our first governance committee meeting. As I mentioned earlier, hot off the press, we just received the final fee schedule for our region, which will be a hot topic for today's call, and also recently executed our SCM addendum with Healthix, our selected QE partner, utilizing a standard agreement developed by the state. So we're making progress. Still lots to do, but I think it's appropriate for us to also celebrate our accomplishments and milestones that we have achieved to date. So on the next slide, what we wanted to spend some time doing today, as you are aware, we and all of the SCNs are diligently working towards ensuring a 1/1/25 service delivery date. And so what this means on 1/1 is we must have the infrastructure and the partnerships and the network in place to on 1/1 to be able to engage and screen at least one Medicaid member, navigate that member to community-based resources, and have a network in place to provide community-based services to address that member's health-related social needs. And so there are several milestones that all of the SCNs must meet prior to 1/1 to give the state confidence that we are ready to go live. A few of these milestones center on governance and overall SCN network management operations. By 1/1, the state expects SCNs to have already recruited and onboarded staff who will support the network. While PHS, I think we were lucky to already have had in place many of the administrative capabilities that will be required of us to manage the network. Given, just the size, scope, and scale of this effort, I think it's also realistic to expect that we must augment current staffing to ensure that we have the internal resource capacity to manage a high-performing social care network. And so we have a staffing plan that was approved by the state, and we are currently in the process of executing on this plan, having already onboarded several key positions that will play a major role in our ability to manage the network and engage with you, our partners, throughout the process. The second key milestone, and release, so you can go to the next slide, is that SCNs must also have a governance committee in place prior to go live. This committee, as you're aware, will be responsible for setting the strategic direction of the network and making key operational and programmatic decisions about the network. As I mentioned earlier, I'm happy to report that our network's governance committee has been established. You'll see that, in my opinion, it's a diverse group of representatives. As many of you are aware, CBOs must represent at least 51% of the seats on the committee, which they do. And so you'll see representation from some of our close CBO partners and maybe some of your close CBO partners, South Asian Council for Social Services, Korean Community Services, God's Love We Deliver, to name a few. There's also representation from government on the committee. We have representatives from DOHMH as well as DSS. There's provider representation, both from a health and behavioral health perspective, including Deb Brown from Health Hospitals, which is Health and Hospitals, which as many of you are aware, is the city's public hospital system that serves a predominantly Medicaid population. Most importantly, the state and we as an SCN want to ensure that Medicaid members also have a seat at the table when decisions are made about the network. And so we have 3 Medicaid members who each live in one of our 3 boroughs represented on the committee as well. The process from application to selection took a little longer than anticipated, but I am happy to announce that the committee met for the first time last Friday at our central office in Tribeca. Unfortunately, I was out of office, so I will ask Zach if there's anything that he'd like to share in terms of maybe some key observations or learning from the committee's kickoff.
Thanks so much, Keisha. Yeah, we had a wonderful kickoff meeting, 2.5 hours. And because there are so many deliverables for the committee in the first 6 months, we will be meeting monthly, even though the state requirement is quarterly. And really what we did in our first meeting was we approved our charter, our governance committee charter. Members were oriented to, this is an official committee of the organization that reports to the board of directors. It's not an advisory group. It's a committee of the organization under 501c3. And so there was a fair amount of kind of compliance training and the things that board members are typically educated about, background on the organization, that kind of thing, background on the social care network, OUNYC. And then we really turned our attention to what's upcoming for the big piece of work for the governance committee in November and December is to review the data that is coming in from our community-based organization capabilities assessment, the community-based organization focus groups that many of you have been participating in, and the Medicaid member focus groups that we've been conducting. This information will form as the basis of how we prioritize and allocate the capacity building resources, the training, technical assistance, and capacity building resources for community-based organizations. So it's a really thoughtful process, participatory process. And it's the governing committee that will be kind of making the determinations of these priorities for funding from the infrastructure pool. So just a reminder, there is the infrastructure grant that includes community-based organization capacity building resources. And then that's not to be confused with the fee schedule that we'll be talking about later, which is the funding for the services that are provided newly under the Medicaid program. So one of the things that this governing committee is working on first is from that infrastructure funding that we received, what are our priorities to help community-based organizations get up and running? So we're really excited. We have organizations both large and small, representing lots of different communities, stakeholders, and enhanced care populations, and different kind of lines of business for CBOs: food, housing, care management. So I think that's a good synopsis of what we covered in our first meeting. And I just wanted to also mention that these members have been invited to join kind of all of these forums and venues so that they can also continue to learn and give us feedback on their experience of how we're doing communicating all of this and executing all of this.
Thanks, Zach. So that's an update on where we are with governance and kind of, network operations and staffing. These SCNs are what we call technology enabled networks to help facilitate the real-time or near real-time sharing of data across the delivery ecosystem. And so as SCNs, there are also several milestones that we must meet prior to 1/1 that are kind of data analytics and technology related. One of the state's expectation of us is that the data and IT platform is in place, and that required functionality is in place prior to service delivery. As you are aware, Unite Us is our network's data and IT referral platform, and they continue to work very closely with us, with the state, with other technology partners and managed care organizations to ensure that the platform is configured to meet the state's requirement. This includes ensuring that it can ingest these eligibility rosters that will be sent from the managed care organizations to determine who's a Medicaid member and who's eligible for some of these enhanced services that reside on the fee schedule. Ensuring that the state screening tool is configured in the platform, and that all of the automated logic that sits behind it that says, you know, based on your needs and what you told me during the screening, we recommend the following services. And so Unitas has also started to engage our region's managed care organizations, while we are also working concurrently to get our contracts executed with them to ensure that they can, as I mentioned earlier, and not only ingest the eligibility rosters, but also support the social care claims process, which will be required of us as social care networks. We communicated in the past that we have also partnered with another technology vendor, Hyphen, to support our network's data warehouse and interoperability needs. We want to ensure that we have a means to not just report to the state on key network activity metrics around screening and navigation and service provisions, but also that we have access to data, whether it be data from Unite Us or data that our ecosystem partners, providers, managed care organizations, and government would like to share with the SCN to improve care coordination, and at the end of the day, allow us to evaluate the network and build a case for sustainability and making these SCNs a permanent part of the public health infrastructure. And so Hyphen is also engaged and working very closely with Unite Us, NICE, and other partners to build out our network's data and interoperability capabilities.
And if I can just, can I just jump in with one comment here? The big goal here with this infrastructure and with this data and IT ecosystem that we're building is so that, because there have been a lot of questions that have come in from CBOs about, are they going to have to become Medicaid billing experts? And what we're trying to accomplish is that our community partners can focus on providing the services and the activities for the Medicaid members, the screening, the navigation, and the proposed services on the fee schedule, and not have to, and the social care network does the billing on their behalf. So that's why all of this is. I just wanted to make sure we started with why when we're talking about this data and technology infrastructure that we're building here.
Thanks, Zach. Another key 1/1 milestone is that data use agreements must be in place with qualified entities, and interoperability with the Shiny is established. All social care networks are required, to partner with a qualified entity. Some of you might call them an HIE. For us, our QE will be Healthix. We are already a Healthix participating organization. Healthix will play a major role in sending the managed care organization eligibility rosters to the network. So these are the rosters that the 14 or 15 MCOs that we will contract with will send to us to say, these are the Medicaid managed members that for your region, and these are the members that are also eligible for some of the enhanced services that are available under the SCN. So they will play a major role in getting those MCO eligibility rosters to us so that Unitas can adjust those rosters to support the screening, navigation, and service provision workflow. Healthix will also play a role in ensuring that our social care network's data, so all of the information that was captured in Unitas around screenings, around navigation, around service delivery, they will also play a major role in ensuring that that data goes back to the SHINY, which is the state's data repository. We recently executed our SCM addendum with Healthix, and they are already working very closely with our technology partners and working closely with the states on, requirements, on specifications, on file mappings, and kind of testing the end-to-end process to ensure that it is seamless. It is also important to note that Healthix is also a selected QE partner for some of the other local SCNs, which we believe to be a plus, as it will aid in data sharing across local and neighboring regions, which I think for New York City is critical, right? Because despite the fact that the state has drawn these regional boundaries, we know that they do not exist in New York City. And so it will also be important that we are sharing information across the various SCNs within the city, as well as some of our neighboring regions. One other technology and data related milestone for 1/1 is that the social care claims process must be in place. As Zach mentioned, all of the SCNs will be Medicaid billing providers, and we will be expected to submit claims to both managed care organizations for the Medicaid managed population and the state for the fee-for-service population that's screened and navigated to local resources for services rendered. And so, as I mentioned earlier, the Healthix, Unitas, Hyphen, they're already actively engaged in discussions with managed care organizations and other ecosystem partners to ensure timely and accurate social care claims submission process. On the next slide, I won't cover the next slide. This was a visual taken from the manual that kind of shows the high level, or from the RFA that just kind of shows the high level flow of information. But the gist here is that there is an expectation of bi-directional exchange and data sharing across kind of the ecosystem. I think one of the big gaps that wasn't reflected on here is government, but it shows, information flowing into the SCNs from healthcare providers, from managed care organization, and information leaving the SCN going back to healthcare providers, going back to managed care organizations, and going back to the state, and the role of the QE in the center of the process and helping to facilitate the flow and exchange of information. So those are some of our key data and IT related milestones that all SCNs, including PHS, are on the hook for ensuring that they have completed prior to 1/1 go live. I think it goes without saying that we can't provide services without a network. And so by 1/1, we must have established our network and have executed contracts with our regional MCOs. A couple of recent accomplishments and activities that are underway. Of course, last month we launched these stakeholder work groups as a means of keeping you, our network partners, engaged and soliciting your input and feedback as we implement these networks. We communicated a while back that we are attempting to be a bit structured and organized around how we contract with our network partners. And so we have taken the approach of utilizing a request for application process to establish our network. And I might have a slide on this, Relitza, on the next slide. To date, we have, released two key solicitations, one of which was a request for CBO network applications back in early August. And then we just recently, last week, released a similar solicitation for provider organizations who are also interested in contracting in the SCN. We'll call it round one. The first round of requests for CBO applications resulted in greater than 250 applications. There was a little fallout, between submission and the point where our procurement team reviews applications for completeness and accuracy, and our third-party team conducts their due diligence process. To date, we have sent out 196 agreements to those organizations who were cleared through the CBO network application process. And as of yesterday, have executed 180 agreements. I know, and this is where I know that there might have been some questions recently. The state kept the bar very low for, defining, who qualifies as a CBO, rightfully so. They want to promote access, and they want as many organizations as possible to be able to participate in this waiver. What that means is that organizations like, federally qualified health centers, who some might consider a healthcare provider, also could apply could apply to participate in the network as a CBO, which many did. After we released our solicitation and during that process, we received some additional advisement and guidance from the state that they would be providing a little bit more guidance around FQHC participation in the network, and any, potentially some guidance around capacity building, allocation and funding and availability to FQHC. So given that we are still awaiting some guidance from the state around the role of FQHCs in these SCNs, we have held any of our participant agreements for those organizations who are FQHCs that applied to participate in the network as CBOs. It's on our radar. It is something that we discuss very regularly with the state. Zach, I don't know if we've received an update recently from them. And so we would love to be able to get these out to you and hope that we'll receive some additional guidance from the state soon so that we can move this process forward with those of you who submitted applications back in August.
Yeah, I can be very explicit and just say our participation agreements had a term in it that said agrees to receive capacity building funds. And we then learned that there may be restrictions on capacity building funding for community health centers specifically. And rather than have to reissue multiple contracts or create a whole lot of confusion, we are awaiting specifics on the restrictions for capacity building funding for FQHCs in version 2 of the operations manual before proceeding to execute those agreements. But we fully anticipate being able to execute those agreements. We also fully anticipate that community health centers will be eligible for capacity building funding. There just will be a different set of restrictions on what they can receive from other types of community-based organizations. And so that's the reason why some of you haven't received your contracts yet. We just don't want you to be confused. We just don't want you to have to go through multiple processes. We take our relationship with you very seriously, and that's why we want to get it right from the beginning.
Thanks, Zach. I'm also taking a look at the clock, and I feel like Zach's going to need at least 45 minutes for his section. So I'm going to try to breeze through these other slides fairly quickly so that we can get to the fee schedule discussion. Based on the initial round of application, we've done a high level analysis of our network's adequacy just to get a sense of potential gaps, both geographically and from a service capacity perspective. Based on the initial round of applications, we believe that if we had to go live tomorrow with those partners who submitted applications back in August, that overall we'd be in a good place, but there are some opportunities to ensure greater network access to certain services. Some of these findings, I think, align to some of our initial thoughts already. Having an existing community resource network, which, might drive the need to partner with some other non-community based organizations to fill these gaps. As an example, home remediation, right? There are several home accessibility and safety modification and asthma remediation services that are reimbursable under the waiver, installing accessibility ramps, handrails, grab bars, mold remediation, pest remediation, installing air conditioners. And so when we think about these services, even today, many of your organizations partner with private contractors who might be considered non-CBO organizations to address their client needs. And so we want to ensure that we have the partnerships in place for facilitating access to these services for Medicaid members who have these needs. Medical respite is another one, ensuring the availability and accessibility of medical respite services within the network. I think this is in another area where there's some opportunity to fill in some potential adequacy gaps, working closely with our provider partners to ensure that network service capacity for medical respite care is adequate. On the next slide, transportation. I think NEMT is another area where we knew coming into this, the likely need to partner with potential non-community-based organizations to ensure network service capacity. I think many of our organizations, PHS included, we work with our clients today to assist with things like fares applications and Access-a-Ride applications, but some of us do not necessarily have the in-house transportation fleet capabilities that we must make available to members who are serviced by the network. And so this is an area where I think, one, we would love to learn a little bit more about what some of your capabilities are in this space, and whether as a network this will warrant the need to explore partnerships with maybe some transportation broker-like organizations to ensure a means of being able to provide NEMT services to our network members. And so in the interest of time, I'll leave it there, but I think this is also, like, these two slides is an opportunity for us to maybe delve a little deeper into these numbers in a future meeting, just so that you as a participant in the network have an overall sense and confidence of our network's adequacy. I'm going to breeze through these next slide quickly so that I can turn it over to Zach. As I mentioned earlier, last week, we also submitted a request for application for provider organizations, health and behavioral health organizations who are interested in participating in the network. It's important to note, as I mentioned earlier, that some organizations who probably technically fall into that provider bucket could have applied to participate in the network as a CBO, and that's okay. However, that we also acknowledge that there are probably some organizations who did not meet the qualifications or were not interested in meeting the requirements that we define for an organization to participate in the network as a CBO. And so we wanted to make this application available to those organizations who would like to participate in the network, would like to receive payment for services that they provide on behalf of the network. To date, we've received a few applications. We're not expecting to receive as many applications from provider organizations as CBOs, but the application period still remains open for another week, and it will follow a similar process to the CBO contracting process as well. So next step regarding partnership development. On the next slide, Relitza, you'll see that one of the things that we want to ensure that we do is promoting access and allowing as many CBO organizations as possible to participate in the SCN. And so what we will do is on 11/6, we will re-release our invitation for community-based organizations to join our network. It will follow a very similar process to the process that we executed back in August, where there will be a request for applications, There will be a 1 week period to submit any questions. Hopefully by now we will have answered most of them. Application window will be open for 2 weeks, and then applications will follow a similar process of our procurement, third-party risk review, compliance, due diligence, which will eventually feed to a contracting process. So if any of you have, other partners who might not have been aware of the application process back in August, please do inform them of this. We hope to cast a wide net and send the invite to as many organizations as possible so that we can get as many CBOs as possible signed up to participate in the network and receive the opportunities available to them under the SCN. Next slide, and I'm going to go through these very quickly. The last few milestones that we must meet for 1-1 really center on training, technical assistance, and capacity building. As Zach mentioned, one of the key activities underway right now, and I might have a slide on this, Relitza, is we've partnered with an organization called iCore Strategies, who is currently facilitating a capabilities assessments with you all, our CBO partners, which will help to inform our network's capacity building needs and serve as an input into a future governance committee meeting in which they will allocate capacity building resources, determine how best we will allocate capacity building resources to the network. iCore is in the middle of executing an online digital survey that many of you might have already responded to. If you haven't, please do try to respond before the deadline, which may be tomorrow. I don't know off the top of my head. I believe it's the 25th. As it will really help to inform our capacity building needs, where there's opportunities to ensure that we have trainings available for you, and of course, capacity building funds allocation. They are also in the middle of conducting group interviews with many of you, as well as Medicaid member interviews, which is also helping to inform both this resource allocation process as well as our overall training, technical assistance planning activities.
I just want to acknowledge here, participation in this was limited to those who had executed participation agreements. And we are planning a separate self-assessment process for our healthcare partners underneath Natalie Tobier, because I know probably those of you who don't have executed agreements on the call are thinking, oh no, I haven't responded to this survey, and I'm not, I wasn't invited, and what about us? So I just want to make it clear that we're planning a separate self-assessment process for healthcare partners, including the FQHCs who don't have executed agreements, in order to understand the capacity building, training, technical assistance, and capacity building needs.
Thanks, Zach. And I did just see on my screen something, a comment around the iCore deadline. I believe it was extended. I don't think it has passed just yet.
It was extended until tomorrow. So 1 week, it was extended by 1 week. So it's due by COB tomorrow.
Thanks, Zach. And so I know there's a lot of information being gathered from iCore, both via the digital survey and the interviews. And there are various deliverables that iCore will be producing, summarizing the results and their analysis. And some of that information will not only feed, governance committee, but it will also be shared publicly with the network as well. And then the last slide on this is, there's a lot of work taking place right now to include leveraging some of the learnings from this capabilities assessment on, training and technical assistance planning for the network. Like, we want to ensure that we are making the knowledge capacity building resources available to you as our partners to build your capacity to service these Medicaid populations. Of course, there's I think there's already an understanding and acknowledgement that you'll need to get trained on Unitas and the workflow. Some of you have said that, you have not utilized the standardized screening tool to date. And so we'll want to ensure that we make available trainings on how to utilize a standardized screening tool. there are expectations from the state, regarding trainings that we need to make available for the network regarding things like trauma-informed training and, trauma-informed care and child abuse and neglect and providing culturally and linguistically appropriate services. And so we are also working internally and, with some of our partners to put together a very robust training plan to ensure that you, our network partners, are trained and feel like you have the knowledge capacity to be able to provide services on behalf of the network. So we'll provide a lot more information as we continue to flesh out our training and technical assistance plan over the upcoming weeks, but want to ensure that we are focusing, and we will be focusing very heavily on not just building your service capacity, but building your knowledge capacity as well to support the network. And we have partnered with various organizations who have expertise in working with many of the enhanced care populations that are prioritized under the waiver to leverage their subject matter expertise, their knowledge capacity, and some of the resources that they already have available to them in-house to be able to support our network's capacity building. So a lot of moving parts, a lot of, milestones have been achieved to date, but there's still a lot to do leading up to 1/1 and beyond. And we will use this forum and other communications with you to keep you in the loop and ensure that you have an opportunity to inform network planning. Some of the key upcoming activities, again, as I mentioned, re-releasing the CBO network application, closing the provider application process and proceeding through contracting for those organizations who applied, utilizing insight from the I-Core capabilities assessment to focus or prioritize resources for the network, and then continuing to work very closely with Unitas and our IT partners on user acceptance and end-to-end testing and workflow validation prior to training delivery for the network. So I know that was a lot of information to digest. I want to ensure that Zach has adequate time to review the fee schedule. So we'll try to answer some of the questions live in the chat. And ensure we can allocate some time at the end of the meeting to answer any urgent questions before we wrap.
Thanks so much, Keisha. And I did have one slide on the preview of the fee schedule, but just to clarify, because I saw some questions coming in through the chat. If you already applied as a CBO, you don't need to apply to you don't need to apply to the healthcare RFA, and you don't need to apply to the second round of CBO applications. If you have a participation agreement or you submitted an application in the first round, the next step will be for you to receive the state's template SCN provider agreement. And so you don't need to do anything more. So I just wanted to make that one point clear so that people don't need to even go in and investigate the other RFAs. If you have a participation agreement or you applied in the first round, the next step will be contracting with this fee schedule that I'm about to present. So just so you have a little background on the fee schedule and how it came to be what it is. So the state designed it in collaboration with CMS. It was a negotiation between the state and CMS. So I know that the state had a lot of requests. Some were approved, some were denied. It was the reason for such a long negotiation of this was a lot of back and forth about things that the state wanted to be able to pay for and things that CMS was willing to allow to be paid for under the Medicaid program. So I think that background context is really important to understand here. Then there was some input requested on the fee schedule, and that input was requested in some areas, but not others. So they came to us and we consulted with some of our enhanced care partners on the areas that they requested, but in some areas they did not request any input. So for example, they did not request input from us on the screening rate, the navigation rate, the care management rate. They requested input from us on things like meal delivery costs, some of the housing related services, but not the navigation piece of housing. Largely things like what are regional utility rates, things that had regional variability throughout the state. That's what they asked for from the social care networks. We gave them input. We gave them commentary in areas where they requested it. We gave them commentary in areas where they did not request it. Things we thought that they were important that they may have overlooked. So I just wanted to make it clear that we advocated as best as we could based on the input from our enhanced care partners and other key stakeholders. Many of the rates ultimately were set, final rates were determined by the state. So most of the rates we set, they came back with something different. Sometimes they met us in the middle. Sometimes they went with those rates that were aligned with Medicaid rates. And many of the rates were set to be consistent with existing Medicaid rates. I want to encourage people when they take a look at this to think about what their kind of bundle of services might look like. In other words, the fewer handoffs that a Medicaid member experiences in this process, the better, right? We know we lose people every time we chop up a process and distribute it across multiple partners. So, and every organization has a little bit different profile of services that they provide, but I encourage people to take a look at the totality of what's on the fee schedule and think about what constellation of services they might provide as a package when you're trying to assess the business model. So if you planning to do screening, navigation, and services, maybe that's a strong and viable model. And Keisha had shown some data about what people said that they were interested in providing based on our RFA process. But we understand that everyone now needs to assess. We want to be sure people know that just because you said you're interested in providing it, it's not an expectation that you provide it. Until you sign that contract, that agrees to the fee schedule rate, you are not bound to provide anything. So I just want to make that very clear. So our capabilities assessment that we're doing with I-Corps is designed to help identify needs you might have to get you started. If there's something on here that you want to provide, but you don't have everything in place today to do it. And what I'm going to present today is just the very high level overview of each of the services. The document isn't too long, but there's detail on each of the services that people will need to look through and understand and think through in the context of their organizations. And I'm not going to go through all of that detail today. What we will do is that we will send, we have permission from the state to share the fee schedule with all of you, as well as any interested applicant to the network. Because we have heard from organizations that did not join because they wanted to understand the business model better first. And we completely understand that. So we have permission to share this fee schedule both with you as well as with interested organizations that have not joined yet. And so we'll share that fee schedule with the detail after this meeting, so that you can dig in and start assessing what works and for you and what does not. And I encourage folks as they're doing this, as they have questions, Keisha and team are here to support you. And so we want to help each organization kind of assess the opportunity in the context of their work, their community, the people they serve, so that those who do embark on providing these services do it in a way that's trustworthy, reliable, and really helps and supports people. My key takeaway from spending some time with this fee schedule is the pathway is narrow, but the potential impact here is great. What I mean by that is there's a good deal of eligibility assessment that is a part of this process. First, you have to be on Medicaid managed care. Next, you have to be a member of one of these enhanced care populations. And then each service has its own set of eligibility requirements. So, not every, just by way of example, we saw on the enhanced care population list, pregnant and postpartum people, up to a year postpartum. That doesn't mean that because you're pregnant, you are eligible for every service on the fee schedule. But then when I say the impact is deep, we have things on this fee schedule like up to 6 months of rental assistance. I mean, that can have a profound impact on someone's life. 2 months back utility bills, refrigerators for people who need to store medications, transportation to non-medical appointments, to the Department of Social Services, to their behavioral health provider, their mental health provider, to their to the congregate meal program. That's my key takeaway. Just looking at this is that the pathway is narrow, but the potential impact here is great. And so our job working with you all is how do we get some of these incredible benefits? How do we make them really as accessible as possible for the people who need them? And that's what we always want to keep top of mind as we're doing this work and figuring out all of the challenging technical details, of which there are many. So I think you can stop sharing, and then I will share the fee schedule. Is everyone seeing this?
Yes.
So, screening. New York is the first state with one of these waivers that has a discrete payment point for screening, separate from the navigation. But I suspect that if you're a community-based organization, you would not decouple screening from navigation and care management. I think that was done so that if there's health screening happening on the healthcare side, they could be reimbursed, and another organization or the social care network could pick up the navigation. So on screening, it's a per 15-minute rate, up to 4 units per year to account for an annual screen and any rescreening due to a major life event. And those 15-minute increments are at $17.50. For navigation, and when I say navigation, this is for the people who are not eligible for the enhanced services. So people on straight Medicaid or people on managed care who may not be a member of one of these enhanced care populations, but they still obviously have a health-related social need. And so they need SNAP or they need WIC, or they need a referral to a housing provider. This is called navigation services. And this is also in 15-minute increments at $17.50, max of 8 units per year. Enhanced care management. So this is when someone has been identified as eligible because they're in one of these, they're a member of one of these enhanced care populations. Here, at the same rate, but it's assumed that a lot more time will be needed to support someone to access those enhanced services. So there's an additional 20 units per month for the waiver, for the entirety of the waiver period. A significant amount more time that you can spend with folks who are eligible for these services and gaining access. In housing, and here we have some really incredible opportunities and also some potential challenges and vulnerabilities to service provision. So we hope those of you who provide these services, we can work closely together and with our enhanced care partner, Health and Housing Consortium, to create as much access as possible. Home accessibility and safety modifications, home remediation, including mold and pest remediation, ventilation improvement, and provision of equipment. This is a member cap up to 10,000. Not all of these services will cost 10,000, and and it is for the entirety of the waiver period. So if you were to have mold and pest remediation, and then you moved and it was 5,000 each time, you'd be okay. But if it was 10,000, that would be kind of it for the waiver period for you as a member. Asthma remediation, the sort of self-management and educational piece of this is again $17.50 per 15-minute increments. This one includes 16 units in person, or 8 units of virtual for the waiver period. And there is some detail about the requirements for inclusion in the self-management education, which are in this document and will circulate to all of you. And then there are the actual products, the inhalers, et cetera. This is up to 8,000 up to capped amount for the waiver period. Medical respite per diem. We went back and forth on this a lot. Thank you to those who provided insight. Ultimately, the state established a range of $245 to $388 per diem. This is post-hospitalization stay up to 90 days per year. A lot of detail here, but that's the kind of agreed upon rate. We do think the higher end of this rate can be achieved by some of our providers. Rent and temporary housing, this is based a lot on the HUD rates. And it's limited to 6 months over the entirety of the waiver period. Utility setup and activation expenses. This is a one-time up to $350 to help you set up your utilities in a new home or a residence. Back payment to prevent you from losing your utilities. This is a much higher capped amount. It's up to $4,566 for back payments. And then utility assistance, this is up to 6 months at $761 cap per month. We think that these rates are pretty good for utilities. They take into account seasonal variability. They take into account fluctuating gas prices and the even the use of home heating oils in some cases. Pre-tenancy services, so helping people find housing. This, I think, is a more challenging lift because they have set the rate at $17.50 for that same 15-minute increments. And they have a 24 units over 6 month cap. So that's 6 hours that you can spend with someone to support them in securing housing. Community transitional supports. This is inclusive of security deposits, purchase of furniture, pantry stocking, utility startup expenses, things you need when you have been in an institution and you're transitioning back into a new residence. And there are a lot of expenses that you're not prepared to afford in that transition. And these are up to the capped amount per member based on the size of the residence that you're transitioning into. Brokers fees, they cover, this is only something they only allow in New York City, so that's good. And they have one-time capped amount variable by borough. I'm not really sure where these rates came from, to be honest with you. And I do want to say that the state has been very cognizant that a lot of this is new and that they're experimenting here. So this fee schedule may change over year as we begin to see what's taken up, what's accessed, what's not accessed, and why. Tenancy sustaining, so helping prevent eviction. This again is at the $17.50 rate, 24 units over 6 months, 6 hours. Housing transition and navigation, 16 units per month. So this is a significant amount more time that you can spend per month with when you're transitioning from shelter or some non-permanent form of housing into a more permanent form of housing. And apologies if I don't use correct terminology. I'm not a housing specialist. Bonnie will be helping us. Bonnie will be helping PHS. Health and Housing Consortium will be helping PHS and all of you housing providers, also Communal Life on our board. to help us sift through and try to operationalize this to the best of our ability. Nutrition, nutrition counseling and education. These rates are in line with what the Medicaid rates are. So this is one where they did not ask for any input, and they set the rates based on what's in the state plan. It includes initial assessment at $24.05 and reassessments at $21.74, 8 units up to 6 months for the waiver period. Medically tailored or clinically appropriate home delivered meals range between $10 to $16, up to 6 months or 11 months for high-risk pregnant and postpartum individuals. Medically tailored or nutritionally appropriate food prescriptions per week, 90. So these are weekly food boxes, but nutritionally tailored, $97 to $146. And fresh produce and non-perishable. So this is pantry stocking, really focused on when you have the ability to store fresh food and it doesn't include, and you need more nutritious food than what you're currently receiving, that's $30 to $78 per week. So that's not the totality of your food needs, it's just the fresh produce and non-perishables. Pantry stocking. Cooking supplies, I should say this one does not include proteins. So this is like not the meats or fish or tofu. It's just produce and non-perishable pantry stocking. And then cooking supplies. This is capped by region. So here the SCN has to closely monitor what people are spending on cooking supplies, kitchenware, microwaves, and refrigerators, because there is a capped amount for the region. And lastly, transportation. Again, this is a regional cap that will have to be closely monitored and managed by the social care network, but also cost-based. And eligibility is only up to 6 months with a capped amount for the waiver period. And the possibility of reauthorizing transportation assistance after that 6 months. So after that high-level overview, there is detail on each one of these services in the fee schedule. So I'm sure there are a ton of questions from just seeing these high-level services and rates. So there is kind of a lot more color on each service in the remaining 20 pages of this document, which we will share with you. So I will stop sharing now so I can see everybody and take any questions.
Hello.
Yes, hello.
Hi. Can you repeat the target groups? I think you said some of the enhanced population or something like that. I'm sorry, I missed it. Like who qualifies? Who's eligible for this?
So first of all, you have to be a member on a managed care plan. And then the enhanced care populations include pregnant and newly parenting folks, people transitioning out of institutions, including correctional settings, people living with substance use or mental health condition, individuals enrolled in a health home, high utilizers, children with a chronic condition, There's one more. Oh, foster or justice involved youth. I think that's everyone.
And when you say transient or institutions, would that include shelters as well, or no?
Yes, it does.
Thank you.
Okay, I think R. Anderson is hand number one.
Hi, Rob Anderson from Educational Alliance. So we have about a 140-year history of providing social determinant of health work. And one arm of our behavioral health arm is a Medicaid provider and does obviously addiction and mental health services. I understand the workflow about how the SCN will do the billing. But from being involved with other groups around the state and monitoring bills that are in, the legislature, my concern is about the OMIG. Anytime you're introducing $6 billion into the healthcare system, I'm sure their ears perk up. So while you may be doing the billing, the actual documentation would be sitting on EHRs and various providers. I don't know if you've thought about a way to enhance our ability to protect ourselves other than the legislature that's out there regarding the OMIG. And there's a two-part question, so I'll ask the next one after.
Yeah, so that's the reason why they have required the use of the data and IT platform for the provision of all of these services, as well as for the kind of payments platform that is that underlies the system. The only interoperability plan that the state has outlined is for screening only on the healthcare side. So there is the possibility to be paid for interoperable screenings, but you have to meet the state's interoperability requirements, and they have only established those interoperability requirements for screening.
Okay. Second part, thank you, appreciate the detail. Second part of that was, so we have Unitas in some of our grant-funded projects already. We need to expand that. And we are part of HealthX. Is there, you mentioned a third vendor that you're using for software. Is there an opportunity for us to also have access to try to obtain interoperability for potential EHRs?
So Hyphen is our data warehouse and our interoperability partner. And we're going to use that to really bring in other sources of data to support both evaluation and performance. And we do have the potential to bring in interoperable screenings through Hyphen. However, they can't build interoperability for things where the standards haven't been released or provided. The state has intimated that ultimately they want to see interoperability beyond screening, but without the technical specifications, it can't be done.
Okay.
Yet.
Thank you.
Emily?
Hi. My question was, there were a handful of those services listed there on this fee schedule where it seemed like there were actual payments being made to clients, like for rents or utilities or what have you. So is those fees listed there, that's the amount going directly to the person who needs them, correct? So then I was a little confused as to what the role of the CBO is in that situation and what the fee for the CBO would be if you help that person to access those funds.
So I've talked extensively to Emily Engel at the state about this, and because we initially, when we provided feedback on the lights went out in here. Initially, when we provided feedback on the fee schedule, we asked if we should build the CBO costs into the rates for things like utilities and rental payments, et cetera. Their response was that the CBO should focus on the housing, navigation, care management, and other navigation units as the vehicle for paying for the like accessing those resources.
Okay, and then just a
So-
quick follow-up on that, like when we were filling out those assessment forms, we don't provide rent or utility funding now, but I think we hadn't really understood that that was a new source of funding that would be available. So of course we'd be happy to do it if we can access that.
Yes, and the I-Core assessment, it's giving us some baseline understanding of where people are, but the communication between you all and our governing committee is close. So we want to hear, specific things that arise out of your review of the fee schedule.
Mhm.
The governing committee is going to make those final determinations on like the allocation for year one. Then there's also allocation for year 2 and 3. But for year 1 in December 12th to be precise. So as you're reviewing this between now and then, any information you're providing to us, we're going to take that into consideration as we're prioritizing the resources for training, technical assistance, and capacity building. So I don't want people to feel like if it didn't get into the capabilities assessment, we're not paying attention to it, or it won't be heard. We will take everything that folks give to us.
Okay, and so then any CBO in theory could begin offering those resources to people now that we know they're available.
That's right.
Great. Okay, thanks.
Miguel?
Yes, hi, good morning. Just wanted to follow up. You had mentioned in regards to those CBOs that had completed a participation agreement and mentioned that they would be eligible to participate in the capacity survey. Coordinated Transportation Solutions has completed those activities, but we have not received that survey to date. And we are an EMT broker and provider. And so trying to understand how this process would work so we can best prepare for the January 1st start date. And so just trying to understand who is sort of on first and who's on second in regards to that.
You have a participation agreement you have a participation agreement as a member of the network through the
Correct.
first round. But you did not receive an invitation from I-Core to participate?
We did not. And we've reached out. We actually have been meeting with, or at least scheduling meetings with folk from the SCN, but those meetings were canceled and subsequently rescheduled for a later date. So we're trying to understand just sort of what is the process, because my understanding is that that capacity survey is closing tomorrow. And so the question comes into play, how will that work?
Yeah, Miguel, I think I responded to your comment. I know we have some time scheduled for Monday. Unfortunately, due to some conflicts on our end, our meeting this week was rescheduled. And I also reached out to our contract management team about your second concern. If you have an executed contract, you should have received the survey. So we'll get back to you today with next steps on that.
Okay. And my second question, just really, will there be any, have there been any projections in regards to volume and participants? You've identified the eligible participants, but has there been any specifics regarding assignment of volume and numbers tied to that?
It's really hard to know, Miguel, because we haven't seen the eligibility file. What was really fascinating when we applied was the state's estimates for who fit into these enhanced care population buckets was really all over the map, and they didn't tell us where they came from. Just by way of one example, it was like they had like 300 re-entering individuals in Brooklyn. And I'm like, this is not right. Right. This is an invisible population. And there's the opportunity here, I should say, for all CBOs to identify folks who are who are eligible, who have not been identified through the Medicaid system, and get them access to these resources. So that's good news, but it doesn't help a lot in our ability to estimate the volume of need, especially given the extent of the eligibility assessment process that we're talking about. So that's a little bit what I was talking about when I said the path here is narrow, but the benefit is deep, is because we still have a lot of work to do to just identify these enhanced care population members and get them through the eligibility process to these resources.
Okay, thank you. Do you have a timing on when you think that might become available? Because I know it sounds like it's quite a yeoman's task based on what you've just explained.
I think the first time we'll have access to the roster is in the first or second week of November. They're doing some testing right now on the files before releasing them. But I think we're going to get our first test, like our first sample eligibility file in late November, mid-November, late November.
Okay, great. Thank you so much for taking the time.
Annette?
Yeah, hi, Zach. How are you?
How are you?
Thanks for meeting with us. I have a question. My daughter does some part-time work with Emblem Health, and they provide, like, she went through the training, and they provide like a listing that goes, automatically to her computer where she can access the files. In other words, people that should be screened, right? People that need to be screened. There are people that a person that didn't take their medication or needs help with a medical appointment, and making that medical appointment. And my question is, are CBOs going to receive a list of persons to be screened to find out if they're eligible?
So
yes.
We're not going to, every SCN is probably approaching this a little differently. We're not going to say, Annette, these are the 5,000 people you're responsible for, and no one else can be responsible for them. We want to meet the members where they are. That being said, any client that you look up, so anyone who comes into La Nueva Esperanza in need of help, when you go into the Unitas system, you will be able to see if they are eligible for screening and if they are eligible for enhanced services based on the eligibility file. So you will have that visibility for anyone you encounter, but we're not going to attribute these lists because we think we should leverage to the greatest extent possible the relationships that members already have in the community with their providers. Yeah.
Okay.
And I'm sorry, we only have 1 minute left. Julie and Sarah, if you send your questions into us to Keisha, kbar@healthsolutions.org, we'll do our best to answer. And Annetta, you work for us, so just stop by my desk. Thank you so much, everybody. I really appreciate all of the participation, the questions everyone's been sending. We appreciate your patience with us as we launch this incredibly large and complex initiative, but we remain excited about the potential impact that this could have on the lives of New Yorkers, both the new benefits that are available, as well as the potential of being all connected by technology for real-time coordination and collaboration. So thanks so much, and we will see you all real soon.